Madhu, what is your first name, Madhu or Murli?
Madhu, sir.
Okay, actually,
It's my surname.
Murli is his surname. Okay.
Yes, sir. Yes, sir.
So, from different parts in India, everybody has got different names. I think this is a popular topic. You got a lot of number of participants at the initial stage itself.
Definitely, sir. I think this will double or triple soon. We
Yeah, I
start
know.
in 1 minute.
So we'll start, sir. Good evening, everyone. I welcome you all to the 63rd chapter of IASO Academics Masterclass series. I request Dr. Sharad Desai, sir, to kindly welcome all of us and to kickstart this session, sir. Sir, please.
Thank you, Jiba. Good evening, everybody, and a happy Holi to all of you. And I welcome you all for the 63rd masterclass that is on proximal gastric cancer. For today, we have got Pradeep Jaykumar and Dr. Arnab Bandyopadhyaya as our examiners, and Dr. Madhu Murli is going to give us the expert talk. And the students, our examinees, are Dr. Samita Mishra and Biplab Mishra, and I wish them with all the best. And I hope we'll have a great session today, and I can see the enthusiasm amongst the people, amongst the delegates today. So welcome all of you. Over to you back, Jiba again.
Thank you, sir. So just like all our masterclass sessions, there are a few instructions for the candidates. Please try to answer to the point. There is all candidates are not required to know all the answers. There is no harm in mentioning if one does not know the answer. It will save a lot of time and it maintains the flow of the session. Examiners, please, examiners keep giving hints all the time. So please keep an open mind and proceed for the session. For all our examiners, in the interest of online viewers, please give expected answers to the questions that are unanswered or answered incorrectly. Also, please go through the online chat as many candidates post their queries related to the discussion in the online chat and try to answer them simultaneously, or we can probably group them together and answer at the end of the session. The rest of the participants, please actively participate. Post your questions in the chat box, and this will keep the discussion lively. Over to you, sir. Now I welcome our moderator, Dr. Pradeep, sir, to kindly share his slides, and we can start this session. Pradeep, sir.
I'm sharing it right. My screen is visible.
Yes.
Yes, sir. Yes, it's visible.
Hope I am audible also. Shall I start?
Yes, yes, please.
Yes,
Start.
please start, sir.
So good evening, everyone, and good luck to the candidates. So I'll be starting with this first case. So first case is a 51 years old male, and he has given the complaints of chest pain and upper abdomen pain for the last 1 month. He was apparently normal a month before and started developing this symptom. And he characterized this pain as a constant and burning type of pain, which he finds at times is aggravated by the food intake. So there is history of loss of appetite as well. And he says he has lost almost 15 kgs of weight in 1 month. There is history of melena on and off for a month. There is no history of abdomen distension. He had breathlessness once, and for which he was evaluated in a nearby hospital, found to have a hemoglobin of 3 grams per deciliter. And he has received around 8 units of PRCs over the last 1 month. In past history, he is a known diabetic and hypertension, on treatment, control for the last 2 years, no significant family history, personal history is non-contributory. Any thoughts? Do you think the history is sufficient? You want to ask some more, or you want to dissect the available history?
Arnab sir, you want to take it from here?
No, sir. You start.
Yeah. Can I ask one or two questions? Biplab,
Yes, sir.
you have seen a patient of 51 years of age who has 3 main symptoms. Hope you got the main symptoms the patient has got. It's weight loss, loss of appetite, and melena.
Yes.
So, and he has received significant number of blood transfusions. So what do you think it could be? What are thoughts in your mind at this point of time?
Sir, with the history of loss of appetite, loss of weight, and melena, which is due to bleeding, I think that this is an advanced malignancy or advanced malignancy, and it may have some kind of distant metastasis features because of weight loss and loss of appetite.
Dr.
So
Biplab,
do you
what
think
takes you to state malignancy? I will rather say it's upper GI bleed, which is keeping the patient with a 3-gram hemoglobin. And of course, patient is loss of appetite is a thing, which might
The loss of appetite is there. Sir, loss of
वो देना कला कोई नहीं रहा पता
Biplab,
Yes.
when you're asked at this point of time, you're not being asked regarding what is your diagnosis or what is the stage of this, something like that. Just you should be telling what is your thought. As Arnab sir rightly said, I'm just thinking about a patient who has a bleeding.
So,
And what makes you, other than the loss of appetite and loss of weight, what is at this point of time tells you it's a malignancy and advanced malignancy?
yes, sir. Because in hematemesis and melena, there will not be such significant loss of appetite, sir.
Okay, see.
loss of appetite
Yeah,
doesn't
you are
mean advanced malignancy, Dr. Biplab.
No, it cannot be. I told advanced because of weight loss.
The weight loss can be for anything. Even in a normal malignancy, the stomach malignancy starts with asthenia, anemia, isn't it?
क्या तेरे पास
Rudra, I think your audio is unmute, I think so.
Sir,
So
patient
Soumya,
is
the other person called Soumya. Soumya is, yeah, Soumya, what is your thought like at this point of time?
Sir, since patient having melena history and with anemia, the patient can present with breathlessness due to some severe anemia symptom. And patient is having significant weight loss, then we will proceed for further to rule out the diseases.
Okay, so at
But
least actually
duration
what I was
of-
expecting his answer is that, see, you have a patient with melena. So what I'm expecting is something pathology related to upper GI.
Yes.
It could be malignancy, it could be benign. So at
Yes.
this point, I'm not expecting an answer like it's an advanced malignancy or it's a metastatic disease, anything like that. I just want an answer like melena, upper GI problem. There's some bleeding from the upper GI. So
and patient is
that's the only thing that I can make up at this point of time. Loss of weight, loss of appetite can be related to so many other things, like Arnab sir was saying. You can have benign conditions also producing loss of weight, loss of appetite, and melena. So I would say that at this point of time, when such a question comes, what is expected of you is to answer that it is a bleed or a massive bleed from the upper GI tract.
Exactly what Dr. Madhu has told Biplab, keep your options open at this point of time. Later on, when it comes, we'll hone down to the exact diagnosis.
Yes.
But at first, keep just upper GI bleed and keep your options open. Let's see.
Soumya, let me ask you one question about melena. What is melena? Simple question.
Black, tarry, sticky stool.
Why is it like that? Why is it black tarry?
Sir, due to since the bleeding is coming from above ligament of trees, so due to some acid content and transit, also degradation of hemoglobin is there, so it convert into black colors.
What is that black lake? Biplab?
Yes, sir.
Hemosiderin, sir.
Yeah, okay. The acid acts on hemosiderin, producing the black color. So the other question is, you meant, is it mandatory that the bleeding is above the ligament of treats always? Can it be below the ligament and still have melena? Present as melena?
Less likely.
Soumya.
Less likely, sir.
Biplab, do you want to modify that answer?
It can be, sir. It can be.
Yeah, if the transit time is more than 6 hours, and if there is acid acting on it, it can be presenting as melena. But usually, as you said, Swami, you're correct. It's usually above the ligament of treats, but rarely below the ligament of treats also. You can have melena because if the transit time is more than 6 hours, and if there is time for the acid to act, and if there is acid, it can present as melena. Okay.
Yes.
Fine. Aram sir, Pradeep, you want to ask something or we'll move forward?
I'm fine, sir.
Why, Dr. Biplab, why there is written that no family history of malignancy?
Sir, because we have to, if we are thinking that this is a malignant case, then we have to rule out any history of malignancy in the patient itself and history of malignancy in the family, any hereditary syndrome associated with it. Like, sir, hereditary diffuse gastric cancer, Lynch syndrome, hereditary breast ovarian cancer syndrome, Pews-Jeghers syndrome, and ataxia, telangiectasia, Bloom syndrome, all those syndromes, sir.
Right.
So do you want to ask any other history apart from what has been given here? Patient has upper abdomen and chest burning type of pain. Do you want to ask any other history which may or may not be significant?
PPI, history of PPI the patient was taking in the past, sir.
Everything to do with the chronic
And
reflex symptoms?
hematemesis is not mentioned. It's only melena is there, no hematemesis. Patient is having severe anemia.
No, would you like to ask for anything related to chronic reflex symptoms?
Yes, sir. Any regurgitation and burning, acidity, and on and off PPI intake, sir. To rule out benign ulcer bleed.
So shall we move on, sir?
Yeah, fine.
Yes, sir. So we are dealing with a case of upper GI bleed. We don't know what it is due to. The history is not so contributory so far. So we'll go on for the examination. So on examination, his good performance status, pallor was present, moderately built and nourished, vitals are stable. General examination and system examination wise, it's non-contributors, more or less normal. And PR, there was no deposit and normal fecal staining. When we did PR, there was no melena. So history has not helped us in any way, adding anything to the available history. So what should we do now?
Biplab, do you want to take the questions? Working diagnosis, what would be working diagnosis at this point of time?
Sir, first I need, because the patient is having anemia, first I need to stabilize the patient.
No, that's not the
Working
question.
diagnosis.
Biplab, that's not the question. The question is, what is your working diagnosis?
Working
His hemoglobin now is 8.9, so it has already been stabilized. So
Sir,
that's one to
now
take care of.
I want to see the location of the upper GI bleed, so I will do a upper GI endoscopy, sir.
No, Biplab, that's not the question. The question is, with this history and this physical findings, do
What
you
is your
have
working
any diagnosis in your mind? Or do you entertain any differential diagnosis in your mind?
Sir, it can be upper GI bleed due to any chronic gastric ulcer and any chronic duodenal ulcer. It can be malignant gastric ulcer.
Okay. So,
And it,
oh, yeah, fine, Biplab, please. We have malignancies on one side, which can present as massive bleeds or melena with a hemoglobin drop. That's you have said that. What are the other conditions you would keep in mind? You said, I agree. Your ulcer disease, I agree. Anything else? Can varicose bleed present like this?
esophageal varices.
Do normally esophageal
This
varices
is
present like
patient
this?
is not giving any history of, sir, addiction, alcohol. So varices, esophageal varices.
Okay, I agree. He doesn't have history of any addictions. That's one point against varices. Any other point against varices?
No history of any palpable mass, no splenomegaly and
Splenomegaly.
no splenomegaly, sir.
Okay, I would say, okay. Any other point? How does varicose bleed normally present like?
Hematemesis, no hematemesis.
So varicose bleed normally presents like hematemesis is a compound. There can be an associated melena, but hematemesis would be an invariably a part of the
Yes,
presenting complaint.
yes,
So
sir.
lack of addictions and lack of presentation of a hematemesis to some extent rules out varicose bleed. But at the same time, the ulcer disease has to be kept in mind. Okay. Do you want to enter any lower GI pathologies? Elderly guy, 51, not elderly, 51-year-old, presenting with significant blood loss without any palpable findings.
Sir, no history of any change in bladder and bowel habit, constipation and all. And
How does right-sided malignancies is
Sir, it can be
normally?
right iliac fossa, It can be right colon malignancy. It can present with anemia.
Yeah, right-sided colonic malignancies do not
but
present
not
normally with
melena.
a yeah, pardon?
But
Sorry.
not melena, sir.
Melena can be, that's what I tried to say in the beginning. It's a melena can rarely be a presenting of right-sided colonic cancer if the transit time is more than 6 hours and if there is acid acting. I agree, as you said, it doesn't normally occur, but commonest presentation of a right-sided malignancy is blood loss, significant blood loss and dyspnea or pallor leading on to cardiac symptoms. So right-sided malignancy should be kept in mind. Arnab sir, you want to?
No, nothing, sir. Proceed.
Pradeep, you want to ask something or?
Sorry, if I was correct, did you say alcohol addiction? If it is not there, we can rule out cirrhosis on history, Dr. Somit?
Sir, non-alcoholic cirrhosis can be there, but
Actually, the fatty liver metabolic syndrome is on the rise, and that has become one of the most common cause of cirrhosis. So alcohol.
the metabolic syndrome
cannot
patient
rule out.
weight is only 51 kg.
Lean NASH is also there. Even lean persons can have metabolic symptoms. So I think
Yes.
you cannot fix your mind telling like if alcohol is not intake is not there, cirrhosis cannot be ruled out based on history alone. So that aspect of it. Shall we ask them how to proceed, sir?
Yeah, so at least at this point of time, you should keep both malignancies as well as non-malignant conditions in your differential diagnosis. At the same time, don't stick to stomach alone. There can be rarely other malignancies presenting as melena. Okay, Arnab sir.
Yes. How will you proceed?
I would like to do upper GI endoscopy to see what's the cause of melena, and lower GI endoscopy also, colonoscopy also.
Biplab, you want to do something differently? You are looking at a different way.
So I want to do an upper GI endoscopy with an ultrasound abdomen pelvis to look for any other mass in the right colon. If upper GI endoscopy I could not find anything, then I will go for lower GI endoscopy.
Do you need to do a ultrasound abdomen and pelvis? So,
sir, it will guide me if the there is any right left fossa mass. Otherwise, I will go for contrast enhanced CT scan for thorax, abdomen, and pelvis.
Yes, Dr. Biplab, I think the even a single investigation costs money. So if it is not yielding any other information which is important, we might think of doing it later. Let's see what has been done.
People, I was happy with the initial part of your answer when you started saying that I look at the hemoglobin and stabilize the hemoglobin. Normally, I would expect that as a first answer for a patient who has had a history of significant blood loss. Human 3 is something very significant. So I was happy when you initially answered that. So before putting your endoscope into this kind of patients, have a repeat hemoglobin. And if it is not stabilized, stabilize it. That would be the answer that would be practically done also. In your OPD also, we do the same thing. We don't pose the patient for a endoscopy on the same day or not even on the next day. You send the patient for routine hemogram. And then because this patient has got, I'm not saying that routine hemogram should be the first investigation in all patients, but this patient has a specific history of 3 hemoglobin and 8 pints of transfusion. So he might have lost blood even after that. So look at the patient's hemoglobin now and stabilize that before ordering any therapeutic or invasive procedures in him. So that was the answer that I would have expected. I like that answer. Stick to that answer.
Vitally, patient was not having any tachycardia and BP was also 120 by 80. So it's like, since vitally patient is stable, so I'm thinking the patient is stabilized.
Your thoughts can be wrong, Soumya. Patients can have low hemoglobin without tachycardia and without any other peripheral manifestations.
That says a compensated
We do see
anemia
that.
can present that way.
It may not be 3 or 4, it can be below 7 or 6, something like that. So even if a pulse rate is normal, even if the patient's vitals are stable, check the hemoglobin of the patient. That would be the most prudent way to go for in this patient. That's what I would expect to do.
Okay, sir.
Okay,
Thank you.
fine. Yeah, Pradeep, we have a hemoglobin 8.9, so that part is so okay, fine.
We have HB of 8.5 and platelets 4 lakhs. With the other routine necessary investigation also, albumin is 4. Rest of the investigations are essentially within normal limits. So we go on.
They want an upper GI endoscopy to be done. So can we go into that, Pradeep? Or Arnab sir, you want to ask something now or move on to the endoscopy?
No, sir. Move to the endoscopy.
Okay.
So we'll move on to the endoscopy. The endoscopy was done and OG junction was normal, esophagus was normal. A large ulcerated lobular lesion of size 8 centimeters was seen in the cardia. Fundus, body, antrum is normal. Pylorus is also normal. D and D2 was entered and they were also normal.
Dr. Biplab, what are the things we look for in a endoscopy report?
In endoscopy report, we see, first of all, we see whether there is any mass or any ulcer. Second, the location of the ulcer. Third is all of the, we should see for any synchronous malignancy in other parts of the upper GI. And we take biopsy with it.
Dr.
What you meant to say meant by saying location of the tumor?
Sir?
What are you specifically looking at when you're looking at the location of the tumor?
When I'm seeing from location of the tumor, whether it is whether it is located, when it is located in cardia, whether it is going to G junction or not, whether it is located.
Involvement of the G junction, that's one point.
Second is involvement of pyloric sphincter and first part of duodenum. And third point is whether both the walls of the stomach is involved or not.
Okay, so we are looking at what is the proximal extent and what is the distal extent of the lesion, which we can have an impact on the management.
Dr. Biplab, we start with the G junction at what centimeter? Like an endoscopy, is they start with first with that. Then number 2, if there is a growth, how much length is from G junction? Number 2. Third is, of course, the description of the lesion. Fourth is, rest of the stomach is normal or not, including the pylorus. Then fifth is whether the distensibility of the stomach, whether the stomach is getting distended or not. These
Yes,
all
important.
things have got the relevance in your diagnosis as well as in your treatment.
Assess a steward category also.
Yes. Now, C-word category is not about, we'll come it later on, how the C-word category, let's see, let's ask you, how will you diagnose the C-word category is only based on upper GI endoscopy?
No, sir. EUS, sir.
EUS. Are you sure? If I don't have a EUS facility in my hospital, I can't assign a
Yes,
C-word
sir.
category.
With CT scan also I can assess.
Yes. We have to see the A of the whole mass, the epicenter of the mass. It is to be seen in also in CT scan. Sir,
Soumya, in this
Yes,
patient, other than the findings given over there, most of the things that we wanted are there. It's a lesion confined to the cardia. So I believe the fundus OG junction is normal. That's also mentioned. D1, D. Any other thing you would like to note in this particular OGD? Any
sir,
other thing you
active bleeding
Yes.
point is there or
Correct.
not?
Correct. So you'd have like to have some mention about whether it's an active bleed or not, and then decide. What will you do, Soumya, in this patient? There's a lesion of 8 centimeters in the cardia. What next?
Sir, biopsy will be the from most representative area, 6 to
Okay.
8
What do you mean
biopsies.
by the most representative area?
Sure, it should not have taken from the necrotic part of the tissue. Most probably,
Okay.
edge of the ulcer will be the part where we should take biopsy.
Have you heard of NBI?
Yes, sir.
Yes, sir.
Have you heard of NBI?
Yes, sir. But in this case, sir, since visible ulcer is already there,
Okay.
and it's
Fine.
very 8 centimeter of size.
How many biopsy would you take, Bipla?
6 to 8 biopsies.
Okay. Hope you know the rationale for that numbers and what is the recommendation, all those things.
Yes,
I
sir.
think we
If
asked
we
last
are
time.
taking more than 7, then there is 98% sensitivity.
Fine. So these questions are being regularly asked, frequently asked in the exam also. Please expect these kind of questions. Arnab sir.
sir. Pradeep sir, anything to add?
Pradeep, you want to add or something?
Sir?
Pradeep, you want to add?
No, so I just kept that bleeding part. I didn't mention in the OG. I wanted the candidate to answer. They answered it well. So, what do you expect from the biopsy? What do you think it could be?
So
Biplab.
this big
Yeah, find
mass,
somebody.
this much big ulcer, most probably due to some malignant etiology.
Yes. Let us proceed to the biopsy report.
Yes, sir. So the biopsy is reported as adenocarcinoma, grade 3.
Do you want any more information in the biopsy report? Or will you, at this stage, will you ask not only adenocarcinoma grade 3, any more things these days we are doing in the gastric biopsy?
For IHC, we are doing
For what?
for MSI testing.
Okay. Anything else?
Other than MSI?
Sir, it for metastatic setting, sir, PDL1, HER2, or
HCR.
Claudin 18 can also be done.
See, in this case, we will not do, sir, HER2 or PDL1. If it is a metastatic case.
Okay. In the metastatic setting, you
Like
would
to
do HCR
investigate
status, PDL1
staging, sir.
status.
We will like to do sir staging for the deciding we want IC, we want.
I didn't get you. What was the answer like? What are you trying to say?
Sir, for metastatic setting, we need HER2 and all. Na? So for that, we need proper staging. So
Okay.
for that, we need CCT, thorax, abdomen, and pelvis, sir.
Okay.
Yes.
Shall we move on, sir?
Yeah.
So we have done a CCT, thorax and abdomen. You can see the video of that CT, the right side of the panel.
Can you play it once and can I ask one of somebody, Biplav, can you read that CT?
Sir, it is a
7 points.
contrast enhanced CT scan of abdomen. It's showing a growth at the cardia, and there is no ascites, no free fluid.
And plasma.
Cannot see any nodes. There is no liver mets.
What strikes you, Biplav, when you're looking at that lesion? Can you go back once again, Pradeep?
Sir, it is
Circumferential. Sir.
No, Soumya, you get it. Let one person answer. We'll get back to you.
so it is involving the lesser curvature.
More than that. Okay, fine. Yeah, agreed. There's, you can say obviously the lesion. What strikes you more than that? Soumya, you want to answer that?
Yes. When you
The
look at the
circumferential lesion, I can see.
And both
Why do you
the
say circumferential lesion? Because I can see the contrast in the lesser greater curvature completely normal.
Sir,
Can you scroll again?
sir, in this,
I think that's some area of necrosis within the tumor. It's not the lumen.
yes,
The
sir.
lumen is on the lateral side. You can see the lumen very well on the lateral
Yes,
side.
sir.
That's what strikes me. That's what I was asking you. It is a polypodal growth into the lumen. Okay.
yes.
And very little of extra serosal extension. There is no
And there
perigastric
is
expanding.
loss of fat plane with pancreas body.
With
the pancreas.
pancreas.
Yes.
Just look again. The lesion gets over before the
Oh,
pancreas.
no, sir. No, sir. No, sir.
The lower
Yes.
limit of lesion is above the level of the pancreas.
Yes, sir.
Yeah. So you have it. Can you describe? Yeah, Pradeep or Arnab sir.
Sir. So what do you see in the CT scan of a CECT? What are the things? Say 1, 2, 3, 4. What
Sir,
will
we
you
should see the growth, the upper extent and lower extent, any adjacent organ involvement, any ascites to see for unresectability ascites, liver mets, any paraiotic nodes, non-regional nodes, and any contiguous organ involvement like left lobe of liver, transverse mesocolon, and pancreas to see for unresectability.
Anything else?
T status, N status, and M status.
Yes, sir.
Anything else, Dr. Samvita?
Everything is covered, sir.
At
No
the same
ascites,
time,
no distant mets, no
at the
lymph
same time,
nodes.
you also look at the vascular anatomy. If the
Yes.
vessels are normal, if there is any abnormal vessels or aberrant vessels, because that will give you a roadmap when you open or do the surgery.
Which
So-
abnormal vessel would you be concerned a patient who is being planned for surgery like this one? Since Arnab sir asked Soumita,
Sir,
which abnormal vessel will be concerned?
Aberrant left hepatic artery,
Can you
which
define
mostly
the
arises from
aberrant?
left gastric arteries.
Pardon?
Aberrant left hepatic artery or accessory left hepatic artery usually arises from left gastric artery. One of the concern while operating gastrectomy.
Good. So, and not aberrant, I would say replaced. Accessory is fine. There can be aberrant artery can be replaced or accessory. If it's an accessory, I don't think you should be too much bothered about that. Practically, you would realize that later. You can take away the replaced left hepatic artery, but if it's a replaced has to be preserved. But it's an accessory, you can most of the time sacrifice at nothing level. So if it's a replace, you should be careful about that. So look at replaced specifically rather than accessory. Accessory is also important. Good point.
Next.
Arnab sir.
Sir, next. Sir.
Okay, now with this CT scan, Soumita, what would you like to? So you have a lesion over there. Again, Soumita, you try to say it's a circumferential lesion, but you see you should correlate to the previous endoscopy that was available. It was normal. OG junction was normal. No? So you
Yes.
wouldn't have a circumferential growth of the lower esophagus with that particular endoscopy finding. So whatever air you saw inside that which was misleading could have been something like a necrotic or something like that. So don't get confused by that. Correlate to the endoscopy. Endoscopy said OG junction is normal. So what can be circumferential below that? It can't be circumferential. There can't be anything. It could be confined to only one of the walls of the stomach. Okay.
Yes, sir.
So what next? Biplav, what next?
Sir,
Pradeep, do you want to scroll next slide? You would showing the CT findings, isn't it?
Yeah, I'll just.
Sorry, Pradeep,
I'll
please
edit
take
out, sir. Yeah. So there was an ill-defined 6 into 4 into 6 centimeter lesion arising from the cardia with ulcerated margins. No extraserosal extension. Few enlarged perigastric nodes. No enlarged retroperitoneal nodes. Liver was normal. No free fluid and peritoneal disease. Chest was unremarkable.
Arnab sir, please take over.
Sir, so how will you proceed with this endoscopy finding, and after the CT scan? How will you proceed?
Sir, I would like to go for staging laparoscopy for this patient.
What is the recent controversies and the A about laparoscopy, staging laparoscopy? Do you do all patients staging laparoscopy?
Sir, according to AJCC and NCC and all, more than T1 lesion should go for staging laparoscopy, sir.
And staging laparoscopy, how do you do, and what all, how do you do staging laparoscopy?
So before that, I will counsel the patient, sir, about the disease and what are the chances of peritoneal mets and how we will be going to proceed for the patient. So after well-informed consent, we'll take patient for staging laparoscopy. We'll take one umbilical incision for camera port and one another incision for aspiration of fluids. And for in our setting, we are going. Yes,
how
sir.
much fluid do you give, and what all places do you give, and how do you do under staging laparoscopy?
Sir, around 300 ml of fluid we instill and give washing from all the quadrants, and we collect 100 ml of fluid which we send for cytology, sir.
Right. It is actually told that you give in 5 places and collect the sample from all the 5 places. It is when it is done for the staging laparoscopy, you have to do it like that. So it comes around 500 ml you have to give in your 100 ml in 5 places and take it out. You can send it differently, and anything else. How do you send? How it is to be checked?
Sir, usually slide block or cell block. Slides and cell block. But slide block image in our setting we not get immediately, sir.
How do you send your sample? I know this is a cell block or a slide. How do you send your sample? Dr. Biplav, anything you want to add?
So it is actually 500 ml installation and collection of 50 ml of peritoneal cytology fluid, and we send in different 5 bottles.
Yes. Remember one thing: if the sample to be sent then and there only, because centrifuge has to be done then and there, and if it is contaminated with blood, please add heparin to it. Next, Pradeep sir, anything?
Your point on staging laparoscopy is very well accepted. It's an extension of your staging workup. But what will be the definitive plan for this patient according to you? You will not be starting at staging laparoscopy, right?
Sir, then we'll go for a neoadjuvant therapy, sir.
If
Perioperative
your staging laparoscopy comes as a positive, then what will you do? What
Sir,
Dr. Pradeep wants to say?
cytology positive, then also we can go for perioperative treatment. But if diffuse peritoneal disease is there, then we'll go for palliative treatment. So,
In a patient who is bleeding for last 3 months and his hemoglobin has been fallen to 3, he has been after 8 units or 10 units transfusion, he is now stabilized to 8.9. Will you still go for a neoadjuvant chemotherapy or a perioperative therapy?
You can take the question.
yes, sir, we can go for upfront surgery also if resectable.
You have seen the CT, right? You have to say whether it's resectable or not.
So it is resectable. Thing is, sir, on endoscopy, no active bleed and any high risk feature suggestive of that of active bleed was not mentioned, sir.
But Soumya, see, before you embark on your treatment plan, two things you should do. One is that you should take the patient and the family members into confidence, tell them the situation and what is the condition, what are the options available. Second, you should discuss in your MDT regarding what would be the treatment modality, and then only take a call on diagnostic laparoscopy, whatever it is. That's one point. Second, as Arnab sir said, it's not a routine case. Please understand that patient had a bleed to such an extent that hemoglobin was 3, as sir was trying to say. So I don't think it's prudent to go for
Yes,
some
sir.
sort. If it is not resectable, then that's a question. But from the CT scan, there are few small perigastric nodes. It was probably early T3 or something like that. So what is the guarantee that patient will not have bleeds during the course of neoadjuvant chemotherapy and have more problems? So a patient presenting with obstruction, patient presenting with perforation, patient presenting with a massive bleed, there are 3 scenarios where you would explore the feasibility of primary surgery. Or let me ask you, is there any other option to control the bleeding? Biplab, the question is to you.
I was just going to ask that.
Right.
Is there any other way you can stop the bleeding and we proceed with your plan?
Sir, radiation.
Okay,
Yes.
Arnab sir, I would take that answer because we do that sometimes. Hemostatic RT is an option.
And how much hemostatic RT, Biplab, you are right, but
Yeah,
how much
sir.
is the dose?
Yeah.
It is 8 gray. 8.
It is 8 gray.
So if the patient, as you said, you are contemplating neoadjuvant chemotherapy before surgery and the bleeding is a problem, then you have to bring in the option of hemostatic RT, then give neoadjuvant. By some reason, if it's a locally advanced disease and you feel that if you go in upfront, you may end up having an inoperable scenario, then it would be prudent to give neoadjuvant RT and then go for downstaging with whatever modality you want and then consider surgery. Here, that kind of scenario is not there because it seems to be inoperable from CT scan. So upfront surgery is an option as well. And again, as Arnab sir said, in this patient, what is the point of doing a DLAP? Because if you are planning for surgery, it's the bleeding that makes you operate.
And if you give
for surgical resection, unless it's extensive peritoneal disease, which would not be the scenario here because you from the CT itself, you know that there is no ascites, no mental fat stranding, nothing to suggest that it would be a peritoneal disease positive. But DLAP, I would agree. As Pradeep said, I would agree DLAP. Arnab sir.
Dr. Samata,
Yes,
if
sir.
we agree to your plan of therapy, like giving perioperative chemotherapy, and we give a hemostatic RT, you want to do anything else other than this? Other than hemostatic RT, do you think of anything before surgery at the same sitting?
No, sir, I'm not able to think, sir.
You have to think about his nutritional status also.
Albumin is 4.
Albumin is 4.
Albumin is 4, but the patient has lost weight. Is there any chance you can hyperimplementation or you can feed him forcibly? And any other thing at this point of time before when you see the patient in your clinic, you tell the patient to start before going off to surgery?
Chest PT spirometry, sir,
Yes,
prehabilitation.
that is a part of, that's a big part of any upper GI surgery. Sir, Madhu sir.
Biplav, at the end of it, what is your treatment plan in this patient?
Sir, so I will go for it, sir, upfront surgery, sir. Total gastrectomy with D2 lymph node dissection, sir.
Pradeep, you want to come in?
You have seen the CT, right? We had a lot of normal stomach left. You
Sir,
still go ahead with total gastrectomy in this patient, or you have any other options apart from total gastrectomy for such patients?
Sir, actually, the CT scan report is not there, but I thought the lesser curvature was involved. So, if the lesser curvature is involved, then I will not get away with proximal gastrectomy.
So, Biplav, you mean to say that lesser curvature involvement is a contraindication for some what surgery? Otherwise, would you think in terms of if the lesser curvature is not involved?
Then I can go for proximal gastrectomy, sir.
Okay,
Is there
so you
any-
mean to say that lesser curvature involvement is contraindication for?
It's not an absolute contraindication, but if lesser curvature is involved, then it will be difficult for me to get margin there. So total
I'm
gastrectomy.
concerned about the margin. How much margin are you intending?
Sir, the growth is almost 8 cm. I am intending, sir, proximal, sir, because this seems to be infiltrative type of growth. Then I have proximal 5 centimeters, sir,
Distal?
and distal, sir, 1 centimeter, sir.
So you said lesser curvature. So where does it become difficult for you in doing a proximal gastrectomy? Which part? The distal margin or the proximal margin?
So in proximal gastrectomy, proximal margin, sir.
No, in this patient, proximal margin will never be involvement with lesser coverage. How does it make the proximal margin difficult? If at all you're saying that lesser coverage involved and I will experience difficulty, it should be in terms of
It is the
distal
distal
margin.
margin. Yes, sir. In this case, if lesser curvature involved, it is distal margin, sir.
Yeah, if the lesser coverage is involved, your difficulty in margin would be on the distal side, not on the proximal side.
Yes, sir.
Okay, fine. No, I'll come to that. I have a presentation on that, so I'll leave it for that. So, Arnab sir, so, but then Biplav, after my presentation, let me know, would you do a, do a proximal gastrectomy for this patient? It is possible, I think. It is possible. So, involvement of lesser curvature by itself doesn't make it a contraindication. I'll come to that. See, what you're looking at, Samita, you want to add on to that? Biplav was saying that lesser curve involvement is a contraindication. What would be a contraindication for doing a proximal gastrectomy in this patient?
Sir, this much large ulcer and
If
advanced
you look at the
disease.
stomach, stomach is also large, Samitra. A large stomach.
Sir, level 1, there is no level 1 evidence at present for proximal gastrectomy for advanced gastric cancer, sir.
You said level 1.
It is advanced gastric cancer. Sir told there is no fat standing.
But this is, sir,
This is a exophytic growth. How will you say it is a large ulcer, which is a exophytic growth, which we have seen in CT scan?
But sir, it is not early, sir. It is mostly T3 and N plus, sir. T3
How?
N plus. T3.
In
Come to
CT
that
scan.
in my presentation. See, it's not the margin that is going to be difficult. It is the clearance of 4 and 5 and 6.
Right.
If
Yes.
you're expecting 5 and 6 node to be involved, you cannot do a proximal gastrectomy. So there are different situations where the 5 and 6 would be involved depending upon the T status, depending upon differentiation, etc., etc., etc. So it's not the margin that is going to be a problem. Margin, you can get 4 to 5 centimeter of distal margin, you can proximal, you can get it. The margin won't be a problem in this kind of lesions. The problem would be the clearance of 5 and 6. So question comes down to, are the 5 and 6 involved? If 5 and 6 are not involved, as Pradeep was saying, this kind of very confined lesion, if our 5 and 6 lymph nodes are not involved, total gastrectomy need not be done. You can very well do a proximal gastrectomy. Anyway, I'll come to that later in my presentation. Let's see. I'm just giving a hint of indications and conditions. It's not the margin, it's the nodal clearance that matters. Okay.
Doctors, Somita, I have got a query. Would you like to do any other imaging studies other than CT scan in this patient or patient of CS trauma? If yes, why? If no, then it's why.
Sir, I won't be doing any other investigation for this patient.
Now, there is a question in the chat box. Would you do a PET scan in this patient?
Yes.
No, sir. I won't be doing PET scan for this patient, sir.
Why?
Sir, sensitivity of PET scan for peritoneal disease is approximately 50%, sir.
Sensitivity of PET scan for what did you say? Like
yes, sir.
sensitivity of PET scan for
Peritoneal disease, sir.
So you're looking at peritoneal disease in a PET scan?
Peritoneal disease only in PET.
So we
do
have
PET for
already
peritoneal
seen in
disease.
CCT chest and
No,
so it's
Soumya, do you mean to say that you're doing a PET scan to pick up peritoneal disease?
Only.
sir, we are doing PET scan for distant meds, sir.
Distant
For
meds doesn't mean
chest
peritoneal
or
disease is not picked up by PET scans.
yes,
If I
sir.
get this patient in a PET scan, para-aortic lymph node 16, level 16 positive. Can we get, then will you proceed with the surgery of a curative nature?
No, sir.
Sir, since patient is as you already said, for this patient or
No, Samita, the point is that the role of PET scan is not to forget about this malignancy. For any malignancy for that purpose is not to pick up peritoneal disease, it's to pick up visceral metastasis, which is not picked up by CT scan, or to clear any confusing finding that was seen on the CT scan. There's a role as the initial staging evaluation, that is the role of PET scan. PET scan doesn't pick up peritoneal disease because the CT compound doesn't pick up the less than 1 centimeter peritoneal disease. So don't say that peritoneal disease picked up a PET scan. You won't do PET scan, that's another reason, but the role of PET scan is not to pick up peritoneal disease.
So whatever we discussed so far is regarding FDG PET scan. So to clarify, so do you think of any other newer options?
Happy PET CT, sir. Happy PET CT.
So what is FAPI PET and how it might help you? Will it help or not help you?
FAPI PET CT is a fibrogen activated protein inhibitor PET scan. It is actually, there is a meta-analysis which suggests it can detect local, regional as well as peritoneal disease more sensitivity than FDG PET CT. Only problem was bone mets. Bone mets FDG PET CT was better than FAPI PET CT.
So
because in FDG PET CT, 50% of gastric cancers are signaling or mucinous, so they lack GLUT1 receptor. So they do not have FDG uptake, but they have FAPI uptake. So
you mean to say we should do FAPI PET in all cases, or what should be the final thing? Should we do a PET or we should not do a PET?
See, there is no universal recommendation for PET CT. If I am suspecting any distant mets and non-regional and distant visceral mets, which is not picked up by CT scan, then I will order a PET CT, sir. In T3, T4, N plus disease.
Dr. Biplav, one thing is we should make it clear, like if you are ordering one investigation and money is not a problem, then you go for a PET CT. Because PET CT has got two components. One is CECT, another is PET, which is actually given. So if money is not a problem, then will you do or will you not do? Then my CECT goes out, because in PET CT I get both. I get PET also, I get CECT also.
So but PET CT,
yeah.
So but PET CT will not have, sir, FDG uptake in 50% of the gastric malignancy.
No, let's not create confusion. I don't think we should be ordering PET scan for gastric cancer. If the recent advances, if there is a question pertaining to any other modality of other than FDG PET, you should answer that. But I don't think as current guidelines or current recommendations or as it's practiced in any major center, PET scan or any other functional scans come into the metastatic evaluation unless You're looking at, as Arnab says, you had a paratic node at station, infrarenal paratic node. You want to further characterize that, or you have a suspicious lung nodule which you want to further characterize. Otherwise, as a standard imaging modality, PET scan or any other functional imaging do not have a standard role in evaluation of gastric cancer patients. Let's put it at that. And there's one question in the chat box: what is the choice in this upfront surgery versus hemostatic RT? I think we have answered that question. It depends upon, in this kind of easily operable or operable looking cases, I would prefer upfront surgery. But if there is any doubt that this patient may have a locally advanced disease in terms of big nodes or infiltration into the pancreatic surface, something like that, then hemostatic RT, downstaging, and then surgery. Okay, case wherein I think downstaging is mandatory, I would go for hemostatic RT, downstage, and then operate. If operable, I would prefer upfront surgery because hemostatic may work, may not work. Pradeep,
Sorry, move on, sir.
we're almost 1 hour now. How much time do you have for the case discussion? 1.5 hours or 2 hours?
1 hour only, sir.
1 hour only.
I think Shijan can tell us, but I think
Then how much more time do we have for case discussion?
Sir, we can go for about another 15-20 minutes.
15-20 minutes. Okay. Fine.
So shall I tell the operative details or move on to the next case, sir?
I think
We'll finish off this one, what was done for the patient, then ask 1 or 2 questions, and then wind up for the next question. We'll fast.
Yes, sir. So we discussed in our MDT. So we plan for an upfront surgery, as rightly pointed out, in view of ongoing bleed. We plan for an upfront surgery. So we underwent a diagnostic laparoscopy, but there was no peritoneal disease, no distant metastasis. So we followed by a proximal gastrectomy, distal esophagectomy, and a D2 lymphodenectomy. There was 7 into 3 centimeter ulceroproliferative growth noted in the cardiac the stomach, just below the OG junction, maybe 1 centimeter below the OG junction.
Okay,
So,
fine.
what
So,
all lymph nodes? So, yes, sir, go on, sir. Sorry, sir.
no, Pradeep, please. You started same question. You go on.
So, what lymph nodes you will consider in a D2 lymphodenectomy when you consider a proximal gastrectomy in such patients?
Sir, in proximal gastrectomy, D2 for the perigastric 1 to 7, I will leave 4D and 5 and 6. And apart from that, 8A, 9 and 11P, sir, for proximal gastrectomy.
Yeah, the point is that 4, 5, and 6.
Yes, sir. I will leave 4. Yes.
Okay, fine. Still, it would be a D2 gastrectomy.
Yes, sir.
Yeah. In the previous edition of Japanese guidelines, D2 dissection was not there for proximal. I hope you remember that, because D2 proximal gastrectomy was permitted only for T1, T2, where only a D1 or D1 plus would suffice. Any patients needing D2 should go for a total gastrectomy in the previous Japanese edition, but now they are modified. It is called a D2 even if you're not taking 4, 5, and 6.
Yes, sir. In 6th edition. Yes.
Good, great. Good answer. Okay, can we, Arnab sir, you want to ask, or we'll move on to the HPR?
No, sir, we'll move on. We'll move on, sir.
Sir, can I ask how they will manage the patient post-op? Do they do?
Okay, sure. Oh, sure, Pradeep, please.
Yes, sir. How will you manage him in the post-operative period? Specific things.
Yes, undergone a proximal gastrectomy and esophagogastric anastomosis. What are the things that worries you other than the common things like your bleeds, etc.? What are you looking at in this patient? You had operated. What is the most crucial thing you're looking at?
Sir, whiting, any drain?
No, that's I get it. All those things are routinely met. I'm looking at one point, one crucial point I'm looking at.
Crucial thing, which is post-op, everybody is bothered. In a
sodium,
GI
potassium, hemoglobin, fine. All is fine.
Leak is everybody's bother, sir.
Pardon?
Leak, sir.
Okay. So how would you pick it up, or how would you rule it out? What is your protocol?
Sir, if a post-op patient is having fever, tachycardia, and because in this anastomosis will be in thoracic region.
You're looking at the vitals of the patient.
Yes, sir.
Agreed. Anything else?
And how the drain is coming, sir.
Okay. Anything specific in the drain? Biplav?
Sir, bilious there will be and there is villous peritonitis, signs of any peritonitis. I will do a dye study, sir, to check whether there is anastomotic
Any
dehiscence.
biochemical test in the drain? Bile, I agree. Vitals, I agree. Anything? Forget. If you're not doing it, fine. Amylase,
Serum amylase.
not doing. Forget. Okay.
Sir,
What dice?
for
Yeah.
this leak, for pancreatic leak, we are doing serum amylase, but
Okay.
for
I agree.
this,
If you're not doing it, I'm okay with that. But I'm okay with the answer that you would look at the vitals, you look at the drain volume, color, bilious tinge, etc. And you would do a dye study. That's what you said.
Yes, sir.
I'll take your answer. What is the dye study you want to do?
so we usually do gastrographin test.
Okay. Pradeep,
Sir,
you want to ask something?
if do you selectively do gastrography study or you do it for all? If you're doing for all, when will you consider? At what day you're in your center, what you're practicing?
Sir, on after 5th day, we do gastrographin study.
You do for all patients.
If it's normal, what does it convey to you?
Sir, it's normal means since for at present era, sir, already they are saying that saliva is already 2,500 ml of saliva daily patient is taking. So chances of if there is no any vitally unstable patient, then chances of leak
No,
is
Soumya,
less.
that's not the question. If the contrast study is normal, what do
Yes,
you infer from that?
sir, patient can take orally and
Biplab?
there is no leak.
There,
I agree with the answer, but any small modification you want to do in that? Practical thing. See, contrast studies are rule in. They don't rule out.
there can be a leak.
Yes,
if the
that's what I
contrast
want.
is normal.
If contrast says that there is a leak, there is a leak. If contrast says that there is no leak, most of the time there is no leak if the patient is hemodynamically stable, but there can be leaks which occur even with the contrast being normal. So contrast study is a rule-in test, not a rule-out test.
And we routinely do, sir, feeding jejunostomy for this patient.
Yes, that's what I wanted to say.
Please.
This is probably Dr. Pradeep has willingly not kept it. That keeping a feeding access or a at least nutritional access is most important.
In our setting, we do keep NJ for all patients.
I agree.
Yeah.
Any feeding procedure, because if the patient leaks,
You have to just keep it a feeding access, whatever way. You put a NJ tube or put a FJ, whatever is your protocol in your center.
But if I may ask a small technical thing, when you do proximal gastrectomy, should you do anything to the pylorus?
Sir,
Pylorus.
mechanical dilatation with the sponge forceps at the pylorus we usually do for pylorus preserving surgeries.
Why it is done? Why do you do that?
Sir, for pyloric drainage.
why do you need that?
Because we have
Wait. Let me see what Samvita answers, then I'll give it to you.
Sir, so that there should not be any gastroparesis or obstruction.
No, Samvita, the question is, you are doing a proximal gastrectomy. Why do you want to do a pyloric drainage? Okay, Biplab.
Sir, because we have removed both the vagus out.
Yes, you're cutting the vagus. You're cutting the vagus, so when the vagus is cut, the pylorus goes in for spasm. So you have to relieve it. Again, that's a debatable thing. But if you believe if you believe in the concept of pyloric drainage, you have to do it. So because vagus are, so the philosophy is that the vagus is being cut. That is why you are being forced to do a pyloric drainage. Otherwise, why should you do that? The pylorus intact. I mean, if the vagus is intact, why do you need to do that? There is vagal preserving proximal gastrectomy which is done in benign conditions, which is not in malignancies. So there is a surgery called vagal preserving surgeries. Fine. So you understand the philosophy of why you're doing a particular thing. Pyloric drainage is being done because you're cutting the vagus.
Yes.
Fine.
Can I move on, sir?
There's one question, role of frozen section. Rudra has asked, what is the role of frozen section? Biplav, you want to do frozen in this patient?
Not in this patient. Mostly in distal gastric cancers. For distal gastric cancer, for the margin on first part of duodenum, because of
Okay, let me ask you, if the margin comes as positive,
Proximal
what will you do?
donut I want to send for
Please,
frozen.
let one person complete the answer, then we'll come to you. Otherwise, it becomes a pandemonium. Biplav was saying that you would do a distal margin frozen section. What if it comes as positive?
So I will extend the margin of resection, and
After
if it is
having
not
fired a
possible,
stapler, after having resected the one, do you think you can really revise the distal margin?
then sir, I will go for
No, let me ask you, have you seen it being done in your center, distal gastrectomy, distal margin sent for frozen?
No, sir, the proximal, the cut on the proximal margin, sir.
Proximal margin for a distal gastrectomy is never a problem. You can give adequate margin. In this patient, that was a question. Okay, Samita, your answer.
Sir,
In this patient, would you do a frozen section?
we are sending in total. We are not doing the proximal gastrectomy, but
Okay, you are
for
doing a
total
total gastrectomy.
gastrectomy, we are sending
You are doing a
esophageal
total
donut
gastrectomy.
side.
In
We
which
are sending
cases you
frozen.
will?
Sir.
In which cases? That means what sir is asking. In which cases you might think of doing a frozen section?
Samita, your answer.
Sir, when we are doing proximal gas, when we are doing upper esophageal cancer, in that for esophageal margin, we are sending donut.
Yeah, I'll take it. For a total gastrectomy or even for a proximal gastrectomy, the margin you are concerned is the proximal margin. There you would do a frozen section because you have an option of revising that margin in case it comes as positive. Your logic of doing distal margin is good enough, but what will you do if you have a distal margin positive and distal gas? You can't do anything much about that. Okay. So you should be doing a proximal margin in a case of total gastrectomy or a proximal gastrectomy if you think there is a chance of that being positive. Because if it comes as positive, you have an option of revising the margin. Otherwise, why would you end up doing a frozen section and then saying positive margin? You can't do anything about that. So you should have an answer to the question that are likely to come after the frozen. Okay, that's why I won't suggest doing for a distal margin. Pradeep.
Yes, sir. So we routinely do for frozen section of proximal margins, be it total gastrectomy, external total or proximal. In this case, it was done, it was negative. Occasionally, we end up in a situation where we had positive margins, we had to revise. And Dr. Samita, if you send the proximal donut for an FS, you have done the anastomosis already. So it should not be done. Before doing the anastomosis, you should make sure the proximal margin is negative if you are sending for an FS.
And number two is probably the diffuse gastric cancer when you are not sure about the margin. In a case of diffuse gastric cancer, here you might see from even in the endoscopy, you will find everything is normal. That's where we call it a well biopsy. We do it. If you in a diffuse gastric cancer, you might think of doing a frozen section on case-to-case basis.
Samantha, in between, you seem to be saying that you will send a donut for frozen section. Do you think that is adequate enough?
Yes, sir. Don't.
You seem to say that you're sending the donut for frozen section.
The donuts are final histopathology. My mistakes.
Okay, fine. No, but what I wanted to say is that donut negative is not negative. Still, you can have margin positive. Donut usually cuts tangentially. It may not cut the entire circumference of the esophagus. So, donut negativity would not suffice. Your margin should be negative. Okay.
Okay, sir.
Pradeep, you want to move on to next case or you want to stick on with this one? Anything else you want to discuss? Arnab sir, you want to?
No, sir. We'll proceed.
Samita and Bipla, you want to ask any questions regarding this particular case?
The patient will go for adjuvant treatment.
Yes. Yes. No, for that you need to look at the HPR. What is the HPR like, Pradeep? You have the next slide, I think.
HPR.
Okay, now tell me, Samita, looking at the HPR, do you want to have any more information or are you okay with this? And if you're okay, what would be a plan of action after this?
PT2 and 0.
Look at the HPR and say, are you happy with the entire data given over there or you want anything more? Biplab, you want to have the margins are commented?
Margins,
The
note negative.
commented? Yeah.
Adequate lymph node dissection, more than 16.
Okay. Anything more? Any other factor you would like to have in this pathology report other than what is already mentioned over there?
MSI is not mentioned.
Yes. Okay. Anything else? MSI
Yeah.
is complete.
Anything
LVI,
else?
PNI?
LBI, PNI.
Yeah, don't miss out on those common things. So when it's been given exam, and this is probably Pradeep was purposeful, because I remember when I saw the slide yesterday, that factor was there. He removed it purposefully to bring in a question, I think. So
And
you should look into missing points and mention that. LVI, PNI. Okay.
And if it is not money is not a problem, then on the very first specimen, you can do everything like MSI along with HER2 status and PDL1, so that if the patient recurs at any point of time, you've got some data in your hand so that you can start. Otherwise, you have to again go for a biopsy or take out the blocks and do it.
Okay, sir.
And these days, people are also doing EBV status, not in India routinely, but in outside Epstein-Barr virus status is also being done. This has got a connotation on the treatment protocol also. Dr. Pradeep, please go ahead. Sir, Madhu sir, anything more to be added?
Just one or two questions I took out from the, this is role of APC for hemostasis. I don't think I have any experience, or I have any opinion on that. Somebody has asked, can APC be used for hemostasis? Probably endoscopic APC. The question was regarding endoscopic APC.
It is argon plasma coagulation. But all the center in endoscopic APC, I don't think, because APC it has to be given. It has to be given intraluminally. You can't give outside APC. Argon plasma coagulation through endoscopic in my center, I don't have, so I can't comment.
We
And
have in our center, sir, but our endoscopies are not happy using that. They say APC will not solve the problem most of the
yes,
time.
It's for
exactly
surface bleeds. APC can be used for controlling surface bleeds, because here you
surface
have
bleed. It
not
doesn't
for this kind of
work
vascular
on a
bleeds.
deeper structures or deeper bleeds. It is for a stress ulcer which is oozing very superficially. It might act.
There's one question regarding routine gastrography study needed for all patients. Again, I would like to answer saying that depends upon institute policy. If you have a policy in your center that you go for imaging, like contrast studies, like it may be gastrography or some imaging technique, you can use it, but it's not mandatory. Especially the patient's hemodynamically stable, as Samita was saying, patient already swallows 500 ml of saliva and all those kind of things. So it's not mandatory. But you have any clinical suspicion, or if your institute policy says that you have to have a contrast study, you do it. Otherwise, it's not needed. There are a few questions about Sievert's type 1, type 2. I think we will not answer that question because the topic is not Sievert. I probably think there will be another session on, because it's a different topic as such, because we will have to delve into so much if you take up Sievert 1 and 2 questions. So that's about the questions in the chat box. Drainage procedure. Again, we mentioned that drainage procedure after vagotomy is again, there is a school of thought it should be done. There is again a school of thought it need not be done. Again, it comes down to your personal and your institute policy. Arnab sir, I do it.
Sir, there is one more question. Can we do Whipples if distal margin positive on frozen section?
There's a very common question asked.
We usually don't do.
When very selected patient, I would say yes, but how many people do it or how many centers do it, I don't know. Maybe I might have done it in maybe 1 or 2 cases, but later on I realized that it was not gastric cancer. First part of duodenal adenocarcinoma. We thought it would be a gastric carcinoma, but it turned out to be adenocarcinoma first part of it. So in a routine way, I don't think people would do a gastrectomy with Whipple for a carcinoma of the stomach. But if you theoretically or practically ask it, it can be done in a very selected group of patients, young patient, fit enough. Yes, you can do it, but the outcomes are going to be very bad.
Pradeep sir, we can proceed to the
Yes,
next case. Already late.
There are some questions
sir,
regarding double track and Merendino, so I think we will answer that during my presentation. I have some slides on
Vijan,
Merendino.
I think we have already crossed the time.
Yes, that's what I was about to. Feeling very bad to interrupt you all, but
Yes, yes.
I'll request our moderator, Dr. Pradeep, to kindly conclude this case, and I think we'll stop with that and move on to the expert talk.
Yes.
So this case, I have given the details of histopath as well. We recently operated him. He's recovered, and now we are planning for adjuvant chemotherapy in this patient. Otherwise, I don't have anything to add regarding this patient. If anyone else have any comments in such patients, maybe for the students' benefit, you can add. Otherwise, we can proceed with the expert talk.
Right. Thank you, examiners and examinees. I request Dr. Pradeep to kindly stop his screen share and request Dr. Madhu Murli to kindly load up his screen. We invite Dr. Madhu Murli to kindly deliver the expert talk for today, which would be into the oncological aspects and reconstruction options for proximal gastric cancer. Over to you, sir.
Yes, just give me just a minute. Thank you, Surgeon. Thank you, IASO, for giving me this opportunity. So what I will try to do over next 15-20 minutes is to give you an overview about proximal gastric cancer. Are my slides visible?
Yes, sir, not full screen yet.
I'll do. So, okay. Now,
Perfect, sir. There you go.
Topic, as initially mentioned, is proximal gastric cancer. So let me make it clear that I wouldn't be dwelling upon Siebert's type 1, type 2 cancers because it's a different entity altogether. So that's why specifically topic has been mentioned as proximal gastric cancers. Now, if you look at the natural progression of gastric cancer, you can see that when all the other malignancies have shown an upward trend, maybe prostate cancer, colonic cancer, breast cancer, lung cancer, one malignancy which has consistently shown a downward trend starting in 1930s is stomach cancer. There are interesting facts behind this downward trend. It is generally considered to be an unplanned triumph. Unplanned because one is refrigeration. What happened with refrigeration is that people started to have more of fruits and vegetables. People started to have preserved from a different kind rather than the preservatives that were being used prior to the introduction of refrigeration. So the pattern of food preservatives changed, pattern of eating habits changed. So you can see that refrigeration has been a major contributor to the reduced incidence of mortality associated with gastric cancer. Another observation is that eradication of H. pylori. H. pylori eradication in all these studies has shown that it reduces the incidence of gastric cancer. So if you look at last 40, 50 or 60 years, these two factors and several other factors has led down to significant reduction in the incidence and mortality of gastric cancer. Now, okay, but there is a problem over there. If you look at this particular chart, you can see that countries like India, Bangladesh, and Pakistan, you can see that the incidence of H. pylori is significantly higher, 80 to 90%. But have a look at the incidence of gastric cancer, just about 5 to 10%. And then have a look at the countries like Thailand, China, or Japan. The incidence of H. pylori infection is much lesser than what we find in our country. But you know that the gastric cancer incidence is much higher. So it's not just about H. pylori infection. There are several other environmental factors that are coming into play, leading on to increased incidence of gastric cancer. But if you look at the trend or site of gastric cancer, even though I said that the incidence of gastric cancer is reducing, if you look at the square boxes, gastric cancer incidence as a whole is coming down. But if you look at cardiac cancers, the rounds, they're increasing both in males and females. So the trend across the world is that the incidence of gastric cancer is coming down. The incidence of non-cardiac gastric cancer is coming down, but the incidence of cardiac cancers is significantly on the rise. Now, what is happening in our country? If you look at this particular chart comparing 1990 and 2016, you can see that stomach cancer incidence has come down. A malignancy which used to be second in rank has come down to fourth in rank. But what has happened to the mortality? Even today, it continues to be the giant killer. or among all the cancers, more than lung cancer, more than laryngeal cancer, more than oral cavity cancer, more than colonic cancer, stomach cancer continues to be the leading cause of death in our country. And this is from our own country, 1990 versus 2016. Now, as I said, there are several etiological factors coming into play. The interplay of all this brings about an increase in the cardiac cancers. But the two things that are highlighted is obesity and gastroesophageal reflux disease. These are the two factors, in addition to other environmental factors, that seem to be contributing to the increased incidence of cardiac cancers, or I would say proximal gastric cancers. Now, in addition to the morphological features or etiological features, they share a common features with OG junction cancers. If you look at acid reflux and H. pylori, gastrin, nitrosamines, obesity, interleukins, etc., in addition to that, at a molecular level, at a genetic level, cardiac cancers seem to be having molecular changes or shared alterations, as you would see in an adenocarcinoma of the OG junction. So you can say that there is an increase in the incidence of that particular complex, the severe type of cancers and cardiac cancers. So the cancers of the stomach are migrating more proximally. That is why we are talking today about proximal gastric cancers. Now, what do you mean when you say that it's proximal gastric cancer? We know that there is something known as Seward classification divides the OG junction type 1, type 2, type 3 based on the centimeters above and below the OG junction. Then there is a stomach which is divided into three parts: the proximal part, the middle part, and the distal part, or the proximal part, the body, and the distal part. So where does the cardiac cancer or the proximal gastric cancers fall into? I would say it's a combination of type 3 plus proximal part of stomach. So when you call a cancer proximal gastric cancer, knowingly, unknowingly, we're including some subset of type 3 cancers of the Seward type, as well as body or proximal part of the stomach. So this constitutes what is known as the proximal gastric cancer. That's why I initially said the etiological factors, the molecular changes, the genetic alteration of cancers occurring in this region are almost similar. Now, interestingly, people are looking more into the proximal gastric cancers. If you look at this picture, the first picture, you can see that they are divided into proximal, transitional, and distal. And there have been more studies looking into nodal spread of malignancy from each of these subsites. And today we have a classification known as the NPTD. P stands for proximal, T stands for transition, and D stands for distal. And this is what happens. So your proximal gastric cancer being subdivided into proximal lesser curvature, proximal greater curvature, then the transitional zone distal. So this is what is happening when you have something like a sentinel lymph node biopsy. Previously, we used to have the final pathological nodal staging to know which are the nodal stations. But today we have sentinel node biopsy, which can tell us microscopically or much before you operate, which are the nodes involved in each of these sites. So now it's been considered that proximal gastric cancer lesser curve can be differentiated from greater curve, but this has not been used into clinical practice as of now. Probably we may be seeing something of that in the near future. Now, let me come to treatment of proximal gastric cancers. Now, you all know that it's multimodality. And in cases of early gastric cancers, we go for surgery, as in the case of first case that we discussed. But you may need to add perioperative chemotherapy. And if at all you start off with surgery, you may give post-operative chemotherapy in these patients. And again, we all know that FLOT is a standard of care as of now. But I wouldn't be touching upon any of those factors. I'll just stick to surgery and two aspects of surgery. What is the margins? What is the extent of nodal clearance, and what are the reconstructive options for a proximal gastric cancer? So as applies for any malignancy, the two basic concepts are how much of margins has to be removed, how much of nodal clearance has to be done, and in the process, can you preserve the organ? And by preserving the organ, are you actually attaining what is known as functional preservation? So these are the four things that we're touching in another 10 minutes or 15 minutes. Before going into the margins and nodal dissection, let's have a look at the classification of gastrectomy as per the current Japanese guidelines. They classify them into curative and non-curative. In curative gastrectomies, you have standard and non-standard. The standard ones are distal gastrectomy or the total gastrectomy where you do a D2 gastrectomy. And then in the non-standard, you have the modified and extended. Extended obviously would be D2 plus or a multivessel resection. What are the modified non-standard gastrectomy? They are the partial gastrectomy, proximal gastrectomy, pylorus preserving gastrectomy, wherein you would do only a D1 or D2. But after this classification has been published, there has been change in the literature. You can do a D2 gastrectomy for a proximal gastrectomy also. When this particular article was published or when this particular classification was made, they mentioned that Proximal gastrectomy is a type of non-standard gastrectomy where you would do only a D1 or D1 plus. But today we know that you still can do D2 gastrectomy, end up doing a proximal gastrectomy. I'll come to that. Again, as was discussed in one of our questions, is there a role for diagnostic laparoscopy? I would say yes. A lot of data on role of diagnostic laparoscopy because it changes the management about 59% of the patients and avoids laparotomy in 40% of the patients. If you don't have a policy of doing diagnostic laparoscopy in all patients and you have a selective policy, at least in G-junction tumors and in bulky T status and bulky nodal disease, you should have a policy of doing a diagnostic laparoscopy. Or else you should have a policy of having diagnostic laparoscopy for all patients or selective policy. But the ideal thing would be to go for a diagnostic laparoscopy in all patients. Now, again, before going into the margins of resection, we also need to understand that margins are determined by the Borman classification. When I say Borman, it's type 1, type 2, type 3, and type 4. It's well read and everybody knows that polypotic growth, fungating, ulcerating, infiltrate. So depending upon the Borman type, you would modify your margins of gastrectomy. Again, for a T1 tumor, irrespective of what Borman type of cancer it is, you would go for a 2 centimeter margin. But if it's T2 or more, depending on the Borman classification, you would have a 3 centimeter margin or a 5 centimeter margin. I'm talking about proximal margin, not about the distal margin of a distal gastrectomy. Again, I would say that in a proximal gastric cancer, you're not looking at 5 centimeters on the esophageal side. You're just looking at negative margins. So when I say 5 centimeter or 3 centimeter margin, I'm looking at proximal margins of a distal gastrectomy or a distal margin of a proximal gastrectomy. Hope I'm clear. I'm not looking at the distal margin of a distal gastrectomy or a proximal margin of a proximal gastrectomy because you wouldn't be able to attain 5 centimeter or 3 centimeter distally and proximally. Then become esophageal gastrectomy. I'm talking about cases of total gastrectomy. So 3 to 5 centimeter margin that you would be aiming at. Okay, let's place the tumor at 3 different locations. This is a distal cancer, body of the stomach, and the proximal gastric cancer. So it comes down to how much margin you want to give, how much node you want to dissect. Again, simple things. A distal gastrectomy, you would know that you have to remove all nodal station. You can have a margin over here. And when you give a margin over here, you leave behind station 2 and station 4s. These are the 2 stations you would leave behind while doing a D2 distal gastrectomy. But as the lesion migrates proximally, you cannot leave behind 2 and 4. You will have to take out 2 and 4 as well. So you end up doing a total gastrectomy, removing 1, 2, 3, 4, 5, and 6. So in a distal gastrectomy, what you're saving behind or what you're leaving behind is the proximal part of the stomach, along with station 2 and station 4s, because the involvement or the incidence of positivity in these 2 stations for distal cancer is negligible, less than 2%. But when it comes to body of stomach, you'll have to do a total gastrectomy because all these nodal stations are significantly involved. So this is the classification. So if you are doing a D2 gastrectomy, you would still leave behind station 2 and station 4SA, even if it's a D2 for a distal gastrectomy. This is something which you all know. Now, what happens if you go for a proximal gastric cancer? So again, as I said, or was discussed during our case presentation, in a lesion which is located over here, getting a margin over here is not a problem. You can get a negative margin of 5 or 3 centimeter. What you're looking at is the involvement of 5, 6, and 4D and need to take it out. So if there is a risk of involvement of 5, 6, and 4D, based on the tumor location, tumor status, or the differentiation, etc., you will have to go for a total gastrectomy. But if the chance of involvement of station 5, station 6, and station 4D are less than 5 or 3 or 2%, you can safely leave behind and do what is known as a proximal gastrectomy, which is the topic of discussion today. Now, again, there are several articles on the oncological safety of proximal gastrectomy in T1, T2 tumors. Just accept as a guideline. But the question is, can it be done in advanced cancers, T3, T4 tumors? If you look at the earlier Japanese classification, proximal gastrectomy was permitted for T1, T2 tumors. For T3 tumor, T4 tumors, they advocated total gastrectomy. But things are changing. It's a large article which specifically looked into the role of involvement of 4D, 5, and 6 in gastric cancers, locally advanced gastric cancers. And they found that in spite of the increasing T stage, if you look at it, you can see that even in T3 tumors with node positivity, the involvement of 4D, involvement of 5, and involvement of 6 was negligible. This article and several other articles, is another article, another Chinese study, all published after 2020 or 2021. These are studies specifically looking into 4, 5, and 6 stations even in advanced cancer, here also you can see that T2, T3, T4. Even in T4 tumors, the involvement is almost 6130, negligible involvement. So there are several articles, several publications, retrospective in nature, which are looked into involvement of all the studies had done total gastrectomy, then proved that these nodal states are not involved. So today we have enough and more data to say that even in locally advanced gastric cancer, if based on the histological type or the differentiation, etc., or the imaging features are suggestive that 4, 5, and 6 are not involved, you can safely leave behind those nodal stations and still do a D2 dissection with proximal gastrectomy. So I would say today that as per the revised Japanese guidelines, if you look at it, even in a D2 dissection for a proximal gastrectomy, you can leave behind 4D in red color, 5 in red color, and 6 in red. So these 3 stations can be left behind and still do a D2 gastrectomy. So the point is that in a T1 lesion, you need not do a D2 gast. You can do what is known as a D1 dissection. T1 poorly differentiated or more than 1.5 centimeter, still D1 plus would suffice. But if the T2, T3, T4 or node positive disease, D2 dissection has to be done. And this D2 can be a D2 leaving behind 4D, 5, and 6. And a proximal gastrectomy, which is shown in this picture. So you would do a margin of resection over here, take out all these nodes, still leave behind 5, 6, and 4D, and have a residual stomach left behind and call it a proximal gastrectomy. Right. So this is an algorithm which I had picked up from an article. So if you look at it, what matters is the size of the tumor, differentiation, and the bulky nodes. So as per this particular algorithm, if the size is more than 4 centimeter, if it's a poorly differentiated tumor, N2 or N3, then you should think in terms of doing a total gastrectomy. But if the tumor size is less than 4 centimeter, or if it's well differentiated, you still can do a proximal gastrectomy with D2 dissection. The bad disease, you'll have to treat it differently. The good disease, irrespective of the T status, you can go for a proximal gastrectomy. So today we can confidently say that total gastrectomy is not necessary for proximal gastric cancers. And mind you, this article was published in 1980s or something like that, 1998. All the articles that I showed regarding the involvement of 4D, 5, and 6 came after 2020 or 21. So today we have evidence that it need not be done. What is the reconstruction you do after a gastrectomy? Obviously, it would be a esophago-jejunal anastomosis. Just 1 or 2 points regarding the, if at all you're doing a total gastrectomy, you would do a pouch or no pouch. This is a conventional anastomosis. This is with a pouch. And this is the jejunal interposition, and this is with a aboral pouch. So what is an aboral pouch? You can create a pouch at this point or another pouch over here. So pouch can be oral pouch or an aboral pouch. Again, the length of the pouch is 8 centimeter, 10, 12, 14, 16. I don't think the final answer has been said. Something around 12 or 14 centimeter would be an ideal pouch. Should you be doing a pouch in all patients? That's also a question that has yet to be answered. But I think today the consensus is that pouch has got its own benefit. There are several studies, which is one of the largest meta-analysis I could find, showed that a pouch creation increases the operating time, but it doesn't increase the complications. Lower risk of esophagitis, lower risk of dumping, and lower risk of disturbances pertaining to food intake. Higher the albumin level, higher the BMI. And all these benefits seem to be existing even beyond 24 months. So previously we used to we used to have a thought that these benefits stay only for some time over a period. A non-pouch patient also behaves like a pouch patient. But at least this meta-analysis, which includes almost 14 randomized controlled trials and equal number of non-randomized controlled trials, proves that pouch is beneficial and the benefits of a pouch remains even after 24 months. So if possible, you should be doing oral pouch or an aboral pouch. Right. Now coming to reconstruction after a proximal gastrectomy, that's what we are talking about. You can just do a esophagogastric anastomosis. Or what you can do is you can bring in a row loop, anastomosis jejunum, and make a side-to-side anastomosis. You can see an anastomosis over here known as the gastrojejunal anastomosis and a jejuno-jejunostomy. This is known as the double track procedure, DT. Or you can bring in a jejunal interposition or jejunal pouch interposition. So I will not be touching upon the jejunal pouch anastomosis, which is known as the Merendino procedure. The third one, the C, is known as the Merendino procedure. I don't think we do it in big numbers, or the jejunal pouch. The commonest anastomosis done are the esophagogastric anastomosis, direct anastomosis with inherent problems that has got, or bring in a row loop and have a double track anastomosis, which is the commonest anastomosis that we make. A lot of articles on benefits of each one of these, demerits, merits, etc. Again, another modification suggested for the double track anastomosis is just have a cut over here. just fire a TA stapler over there, so that in this anastomos, the first anastomos, you can see that the foot can go two ways. It can go into the stomach or it can go directly into the jejunum. But here, the foot can go only into the stomach and come like this. So the amount of reservoir capacity or the amount of time the food remains in the stomach increases. What additionally you should do when compared to the first picture is that you just need to fire a TA stapler there. No need to cut it. So again, this has got its own problems because there's a reflex. Reflex is one of the biggest problems. As I said earlier, we are transecting the vagus. You do a pyloroplasty or don't do a pyloroplasty. Irrespective of that, there is a significant number of reflex. To reduce the reflex, there are so many procedures described in addition to the anastomosis. A wrap or a fundoplication kind of thing, and a SOFI, what is known as side overlap esophagogastric. In case you are interested, you can go back and read this. Or these are some of the procedures which have been described to reduce the reflex associated with the esophagogastric anastomosis, which is much lesser in a double track anastomosis. So, which is the best reconstruction option? There's so many articles on the various reconstructive options available and the benefits, the quality of life, etc. So, combining all the data from all the published literature, what I could find out is that quality of life better with double track, reflex, nausea, vomiting, adverse effects lesser with double track, nutritional effects, weight gain, iron deficiency or B12 deficiency better with double track. So if you have a choice of double track versus direct anastomosis, the evidence says that double track anastomosis is better, but there's a catch over there. Read between the lines of these articles. You would find that if there's a large remnant stomach, more than 2/3 of the stomach is remaining. I don't know how more than 2/3 of the stomach can be left behind doing a gastric. Probably in a very large obese person, it can be done. But if the stomach volume is good enough, any recon is good. But the stomach volume is less, DT is better. More than that, technically, if the stomach volume is lesser, I don't think you can pull it up to the OG junction to the anastomosis safely. So, depending upon the stomach volume, you can choose an anastomosis. But if you have an option, it would be better to go for a double track anastomosis, which is the first one I have shown, with a cut or without a cut, which reduces the incidence of reflex, which increases the nutritional capability, etc., and also helps in weight gain and reducing the iron B12 deficiency. Now, the question is, can you do a proximal gastrectomy in patients who are being treated with neoadjuvant chemotherapy and then considered for surgery? I come across two articles. Again, I don't think the final answer has been said, but still I bring out two articles, again published in 2024, Chinese article, which looked into around 150 patients. They mapped the lymph nodes, and this particular heat map shows that even 4D and 5S is still in the green zone, not in the gray zone. It's around 5%. So they have questioned or said that proximal gastrectomy post-chemotherapy in patients who had nodal burden on the higher side, in spite of the fact that they were downstaged, is not safe enough. But there's another article, again a Chinese study published in 2024, which says that whether it's proximal gastrectomy, total gastrectomy, downstage, they are same outcome. What matters is the tumor regression grading. The tumor regression grading has been good enough, and radiologically there has been good response to nodal stations. You can safely leave behind 4, 5, and 6. I don't think the final answer has been said, so I would like to modify the initial, algorithm I showed. In a T1, N1, T2, N1, T3, N1, confined to the proximal stomach, you can do a proximal gastrectomy with D2 dissection. We have significant amount of evidence, oncologically safe, functionally safe. But if it happens to a bad bulky tumor, you wouldn't normally go for a primary surgery. You would go for neoadjuvant chemotherapy. And in this kind of patients, you would reassess the patient. And as per the data available, it seems to suggest that in good responders, you may go for a proximal gastrectomy. But if it's not a good responder, you have any doubt regarding the positivity at 4 or 5, better go for a total gastrectomy. So proximal gastrectomy is an oncologically safe surgery in selected patients whose lesions are confined to the proximal stomach. Thank you so much.
Thank you, sir, for the excellent expert talk. We will
We'll ask, yeah. So I think from the Q&A, we covered most of the questions during the mock exam itself. I'll request Madhumurli sir to kindly just go through the Q&A right now, because whatever we had on our slides, you have already covered. So
I think many of the questions were regarding the Merendino procedure.
yeah.
The Merendino procedure actually is a jejunal interposition. You cut a segment of the jejunum and bring it up. And But I think functionally, I don't find why a double track. I hope people who understood what a double track is. Just you're doing a Roux-en-Y esophageal anastomosis and just a side-to-side gastroesophageal anastomosis. So you're creating an alternate path for the stomach to be functional. So the reservoir acts well, the reflex comes down. So if given an option, I would think double track is a less complex procedure than a jejunal interposition. There can be different opinions, so which will answer most of the questions pertaining to reflex and the complexity of surgery. That was regarding some Merindino. But if asked Merindino procedure, people should know what a Merindino procedure is. And if there's a short note on reconstructive options after proximal gastrectomy, all the pictures I showed should be part of the picture. One is the conventional anastomosis, one is the double track, one is the Merindino, and one is a jejunal pouch interposition, which is a much more complex thing. So all these reconstructive options and their outcome should be part of the short answer. Again, other questions for diagnostic laparoscopy, which I think I have mentioned, you should have a policy for an institute. The ideal policy would be for all gastric cancers. But if you have a selective policy, which I have in my center, we have a selective policy. Before the initiation of the chemotherapy, we go for a diagnostic laparoscopy in bulky T4, O junction, etc., because we find it difficult to slot in all the patients for diagnostic laparoscopy. But ideally, it would be good for all patients. Second is feeding jejunostomy. Again, I would accept the fact that feeding jejunostomy would be advisable, but there are centers which have stopped doing feeding jejunostomy because of complications associated with feeding jejunostomy and gone back to nasojejunal feed. So some sort of feeding procedure which would sustain the patient for a longer period in case the patient develops a leak or some surgical complication would be advisable, either in the form of a feeding jejunostomy or a nasojejunal feeding, because 5 to 10% of patients can still leak. So to tide over the leak and to conservatively manage per patient and to maintain the patient's nutrition status, we would need some feeding procedure. And again, I think proximal gastrectomy with D2 is standard now. Proximal gastrectomy with D2 was not standard in the previous version of the Japanese guideline, but with current evidence, I would say with conviction that proximal gastrectomy with D2, leaving behind 4, 5, and 6 is a standard procedure. And any other things?
Can I also ask the other examiners, Dr. Arnab and Dr. Pradeep, about their views on their choice of reconstruction technique, both in a total gastrectomy as of today, as well as in a proximal gastrectomy at their center? Dr. Arnab.
For total gastrectomy, usually we do a esophagojejunostomy. And for a proximal gastrectomy, my preference is a double track method.
Right.
Because it is easily reproducible and it is basically easy to do. Dr. Pradeep.
The only point I want to PGs to understand is the concept called aboral pouch. We all know the oral pouch, where you create a pouch at the anastomotic site into the esophageal. But there's something known as aboral pouch, where the pouch is created at the jejunojejunostomy. But the point is that whatever you do it at the oral end or the above end, the functional outcome are the same, because you're creating a reservoir, foods to stay back for some more time. So nutritional aspects are same, oral pouch or aboral pouch. There are two pouches, oral and aboral pouch. But I think conventionally we all do the oral pouch rather than doing a aboral pouch. I have never seen somebody do a aboral pouch. Anybody? I don't know.
Dr. Pradeep, you're muted.
So for total gastrectomy, we generally do Roux-en-Y esophageal. Currently, we don't do pouch for all patients. Proximal gastrectomy, most of our patients gets proximal esophageal gastric anastomosis only. We did double tract in a few cases, but it's not a routine as such. Maybe we'll try and do it more frequently. The number of proximal gastrectomies are less. It's not huge in any center for that matter. Usually we end up doing total gastrectomies. Proximal gastrectomies we do less often. Maybe in those cases, as I said, double tract anastomosis should be a better choice in compared to a simple esophageal anastomosis.
So final question that we have on YouTube here is, you mentioned about station 5 and 6 lymph nodes to be ruled out before we embark upon a proximal gastrectomy. How would you want to stage and rule out these lymph node stations before you actually do a proximal gastrectomy?
The question is regarding the role of endoscopic ultrasound and FNAC.
Correct. So either EUS, or do you send a frozen intraop, or how do you go about it?
Frankly speaking, as Pradeep was trying to say, we are doing proximal gastrectomy selectively for early lesions. We have not started doing proximal gastrectomy for advanced cancers or post-chemotherapy patients. But the data is accumulating regarding the oncological safety. So we don't have our own data on what puts the positivity or how are we going to evaluate it. And the articles published, which says that you can leave behind, have not used PET scans or endoscopic ultrasound guided FNAC of those stations to rule out the involvement of those stations before doing proximal gastrectomy. Even the articles that I quoted had ultimately done total gastrectomy and then said that it is not needed. So we are ready to come out with large data with long-term follow-up of these patients on the development of isolated 4, 5, 6 recurrences in T3, T4 tumors. Currently, we're looking at, I would say it won't be bad because we know that most of stomachs fail systemically. So leaving behind 5% or 2% involvement, if at all they are there at 4, 5, would make a larger difference in long term. Patients would develop peritoneal disease or a liver metastasis. So we are yet to have a conclusive flow chart on what should be the way of evaluating 4, 5, 6 before we say that. Currently, we are going with the CT scans. Nothing more than that. But as somebody said, endoscopic ultrasound FNAC feasible, that would be a good idea. Or a sentinel node biopsy and on-table frozen would be also a good idea.
Right. I invite IASO Secretary Dr. Rudracharya for his comments. Sir also has a keen interest on stomach cancer and he's been on the chat and Q&A throughout the session.
I know.
So
he's a proponent of double track. I heard him speak on that multiple times.
Sir.
Yeah, I think our preference is double track because after I burnt fingers with 3 of the direct esophago gastrostomy, what happened is the patient continuously presented with gastritis. And in 2 cases, I had to convert it afterwards. Again, going inside and doing Roux-en-Y and otherwise the patient is going on complaining and all that. So after that, we stopped doing without double track. We always do with double track. And very nicely explained, I think Madhu gave a complete picture of all the proximal gastric cancer. There is nothing left except one point is that when you have a long segment disease, sometimes Seibert type 3, which is extending to the stomach and also extending to the esophageal side, there the role of frozen is very important because what we get is a proximal margin positive. There you might need to convert it to a Ivor-Lewis kind of procedure, but if you are going for a total gastrectomy, your esophageal, your jejunal limbs would be reaching to the proximal margin, and there the role of Rosen and revision of the proximal margin is important. And in this case, sometimes, if you are going higher, you might need to convert to a Garlock's approach, what is called as left thoracoabdominal incision, because going higher from abdominal side, you may not be able to reach. So in those cases, we just take one intercostal space, connect it to the midline incision. It will come as a half Y or J-shaped incision. There you can take the limb higher and you can do the esophago-jejunal anastomosis through the Garlock's approach. So I think it was a very brief and case was also very good case chosen, and I think the student did well. Thank you very much, everybody.
That brings us to the end of our webinar today. Thank everyone for logging in. Thank all the examiners for their valuable time. Thank you, examinees, to taking up this challenge of going live in front of the audience and answering questions boldly. You did very well. We meet again on 25th March, 2 weeks from now, where we'll see in practice through video tutorials about all the gastrectomy and reconstruction things that we spoke today in theory. We'll see them in a video format, and we request you to kindly log in for that as well. 25th, Tuesday, 7 p.m. With that, we would like to thank you for logging in and